I'm Dr. Justin Ott, physical therapist and founder of Ott Physical Therapy. Getting to join you today with a special guest in front of mine, Michael Turnwald. Mike, do you mind telling the audience a little bit about yourself and who you are?
Sure, Justin. Thanks a lot for having me. Again, I'm Dr. Mike Turnwald. I'm a physical therapist, board certified in sports and orthopedics, strength conditioning coach, dry needling, musculoskeletal ultrasound. My background is I have a private practice out here in Columbus, Ohio, treating anything from orthopedics, sports, vestibular primary care, a little bit of neuro. But along with running a private practice, I do some teaching at Tufts in Boston, Bowling Green University, and previously have taught at Ohio State, University of Pittsburgh. And I do quite a bit of professional training for emergency medical response. So I travel around with Cogent Steps, and we certify people to be sideline providers, train them to be emergency medical responders. And I get to do a nice bit of travel with that. So through that, I've been able to work with the UFC, Major League Baseball, different groups within the military, and a lot of other small private practices and large practices. We've taught at universities and hospital systems all across the country. Outside from that, I also have been doing some private contracting, so side contracts with the Olympic Committee. For the U.S. Olympic Committee, I've worked strength and conditioning for Ohio State University Athletics, University of Pittsburgh Athletics, and also cover Broadway productions here in Columbus when they come into town.
That's incredible. That is quite the resume building that you've been doing over there. So that's impressive to hear. And with that being said, I can't think of anyone that could be better suited to talk about the topic that I want to bring up today, which is just physical therapy, exercise, and how it can be different for everyone, different exercises, whether it's a different injury or a person. I think it's a lot of benefit for us to talk about in our profession, being specialists in exercise, to kind of talk about the public of our opinion and what we do and how we view exercises. So, can you help give a basic explanation of what I mean by different exercise types?
Well, absolutely. So when we're trying to describe or prescribe an exercise, we need to decide, are we trying to give that for strengthening purposes? Are we trying to give it for improved balance, awareness, or neuromuscular control? Or are we trying to improve range of motion or mobility? Those are three of the main ones. We can also get more into the Duffy of talking plyometrics and explosiveness, but for the most part, it's, do we have the strength to move? Do we have the room to move? And do we have control over that? And those are the main three paradigms that we look for when we're trying to give any type of exercise. And so any exercise that we give should really focus on just one of those things. We don't want to be trying to juggle different topics and fit within all three realms at the same time, because just like you might have seen when you're at home, if we're trying to do multiple things at once, we don't do any of them well. So if we're trying to do a strengthening exercise, we want it to be strength focused. Same way for neuromuscular control or balance. So in terms of strengthening, we can split strengthening into three main types. You've got isometrics, concentrics, and eccentrics. Each one of those has to deal not so much with the total motion, but it's in reference to a specific muscle. So say that we have identified a muscle that's weak. We want to pick an exercise that's going to focus on that muscle. We can do a squat, but that's working multiple muscles. That's a component, that's a composite movement. But if we want to do like an isolated movement, say we talk about a bicep curl, that would be a bit more focused on one muscle. Even though it's not truly one, we can at least really zone in on that.
It's a great way to look at it, a great approach and explanation of it. So well done. Strength and range of motion are definitely two common things I think in every single evaluation I've done. I shouldn't say every, but a lot of them when people come in, those are components of us as therapists. We want to assess. We want to get an idea of what your mobility is, and then what your strength is, where to hone in on the impairments, so we can focus on that. So, in your opinion, like when do you find stretching and range of motion exercises to be the most valuable when you're seeing someone for the first time?
So for the first time, I want to be able to take somebody through and see what's available, see what's not available. If we're going to try and improve your movement, we need to see, how is it going to move? You have to clear the road before you can pave it, right? So we have to try and open up that range of motion. We have to try and improve that flexibility. So whether that be doing some passive stretches, a lot of times active stretches are going to be a lot more effective. So we can talk about either hold relax exercises where we actually try and use our muscles to increase that range of motion, and then we lean into it, or we can even do, manual mobilizations like you can with your hands, or have a physical therapist help you with that. Or we can even do, very gentle almost ballistic stretches, which is basically trying to move back and forth through the movement, which allows the muscles in the natural stretch response to let those muscles actually try and open up. It kind of goes along with that line that movement is medicine. The body responds to movement and actually is able to let itself relax and then be able to do further movement as well.
I think that's it. Whenever I talk to people about stretches, I think it's, oh, I do my stretches in the morning for 5 minutes. I'm like, oh, what are you doing? What are you showing me? And I think they're on to things. I think there's a lot of good, valuable information out there that you can get tutorials for or little demonstrations. But to really get like the honing in, like breathing it out, trying to get the most relaxation, the most out of things, or maybe not a stretch, but a mobilization, different approach might not always be the same things that the general public might view that we look at and that we see the benefit of doing. But I want to go back to a couple of things in terms that you talked about earlier: the isometrics, concentrics, eccentrics. Can you explain what these terms mean and when do you usually pick one over the other when treating?
Yeah, absolutely. We split it into isometrics, concentrics, and eccentrics. Again, these are all in reference to just one isolated muscle, not a whole movement. So if we talk about squats, if we go up and down for the squat, we're actually getting isometric, concentric, and eccentric movements in different muscles throughout that whole movement. But if we want to break this down into something simple like that bicep curl, an isometric is going to be where that muscle is trying to tighten, but it doesn't change its length. So that muscle is working, but it's staying put, right? It's not shortening, it's not lengthening. So those isometrics are great because, for one, they're actually really useful for tendonitis or tendon pathologies. And we also see that with isometrics, they're a relatively safe way to build strength. We also see that they're a great way to actually improve your muscle activation, because we see that as you're running through an isometric, the longer you hold it, it actually increases action potentials. You have a summation of those action potentials that you're recruiting more and more of that muscle as you hold it. So they're helpful for early stages in rehab when, say, we've had a muscle that is shut down due to pain or surgery or just wear and tear. If we want to try and look at something like a concentric exercise, this is more typical of what we think about with strengthening. If we're sitting here and we're doing our bicep curls, we're trying to curl up that muscle, our biceps, as it contracts, it tightens and it shortens. It pulls the two ends together. So that's where the muscle is able to shorten, create some force, and that's our traditional, so to speak, strengthening. Um, a lot of your focused machines that you're going to find at the gym, your isolated machines, your weight machines, are going to do individual muscles like a bicep curl machine, a tricep machine, a hamstring curl, or a knee extension machine for your quads. These are all going to focus on largely the concentric exercise. But what we can see is that you can also actually use those exercises for eccentrics as well. An eccentric is what we call a negative. It's where that muscle is having to work. The muscles are firing, trying to pull together, but it is actually still lengthening, right? These are really helpful because they're one of the best ways to build strength, either just by doing gradual control, which helps that neuromuscular component, or if we actually superload the muscle, we can actually perform eccentric strength at more than 100% of our 1 rep max. Up to 110, 120% of that weight, we can actually produce force, even though we can't voluntarily kick that out or voluntarily curl that muscle, curl that weight. We can actually control that weight as we decelerate. So it's actually really helpful to help build strength at a supermax level, but also from injury prevention. A lot of injuries that we see, we talk Achilles strains, hamstring strains, tend to happen during the eccentric phase of different sports activities. So the more that we can actually strengthen in those types of movements, less risk of injury that you're going to be at.
Yeah, it's a very important concept going through everything you just talked about, especially when I hear people saying, yeah, I can curl up to 999 reps and everything like that. And I'm just thinking the overuse of what you're doing on that and the different pathologies or tendonitis that might be coming down there, their ballpark in that area if they keep that up. So definitely incorporating these things just from a standpoint of, I'm going to the gym. What am I focusing on? What is my purpose? When you go to the gym, what are you working on? What is your exercise? And what are you trying to get out of it? So I think that always knowing what specifically you're trying, what your goals are, is a great way of incorporating everything you just said. So, and then on top of just knowing what those different components of exercises from that standpoint are, I love being a physical therapist that can apply that knowledge to the creativeness of trying to match what the injury or what the patient or the client is, to make it one interesting, engaging, because they're going to be more motivated to do that, get more out of it, but it's fun. It's just more fun for me, at least, to think of all the different ways we can challenge them. Some of my favorites are definitely going to be plyometrics, agility, and sport specific training. So
Oh
I know
yeah.
you probably got a handful of sport specific things that you've come across. So can you give us some explanation what I mean by plyometrics, agility, and sport specific training exercises, and some examples when you like to incorporate them in your treatments?
Sure, absolutely. You're kind of talking about like the flashier, the sexy exercises, right? All
Yeah,
the
that's one way of looking at it. Yeah, definitely.
so so absolutely with plyometrics, agility exercises, they're going to be more explosiveness based, more speed based. It's where we start to factor in one more component. So not just about whether or not the muscle is contracting or lengthening, it's going to be about how fast you add that temporal component. So do I want to do it at a tempo, whether it be slow or fast? And so we'll actually end up probably mixing those if you're going to be working on, jump boxes, ladder drills, or even lateral explosiveness. It's going to be probably a slow phase, and then you're going to hit a trigger, and then you're going to have to try and explode. So how fast can you work on that rate of force production? We think of that as though it's isolated to sport, but it can become something as simple as that sit to stand. We talk about people who are just trying to get up out of a chair. Just like a rocket taking off from its landing pad, it needs some explosiveness, some acceleration to get up off of that pad, just like we need to get up out of that seat. So we need to have some ability to generate some force to get up out of our chairs even throughout the day. So working in some pieces of some of the agility, some of the plyometrics is going to be important. Um, One piece with plyometrics is that it's going to have a very quick lengthening phase of the muscle followed by a quick shortening phase. So it's going to be how fast are you going to be able to turn over from that lengthening phase into the amortization phase into that contraction. That's where you get your force generation.
Yeah, definitely. I love working with athletes. Well, I shouldn't say I love their injuries, but I love working with them to get them back to where they're going to need to be. And knowing that hey, it's a lot more stress on the body, on the joints, on the muscles, on all the tissues involved, puts you more at risk. So knowing what to do to get them back safely, that's a lot of times I see people doing it a little too soon. That's where you get some setbacks. But knowing what you're doing to try to apply that into it, and I love it. The little inertia to get it going, the rocket ship, body motion stays in motion once you get that going. So good application of that. Another thing, not just I guess the sexy exercises, but thinking about the different needs of the patients too. So as fun as this talk about just a sport specific, like you're saying, like the sit to stands, get up and down. Whether you're working with an injured worker, acute injuries, or just normal wear and tear or chronic symptoms, I think it would helps you in what helps you in deciding when these individuals are ready to progress and increase the difficulty in their training. Whether they're a worker trying to get back to the job, just someone trying to get through the day to day to go grocery shopping, or even an athlete getting back to sport.
So the keys that I'm going to use to try and help determine whether or not they're ready to progress to some of those more explosive exercises are going to be whether or not they have the strength to do it slowly. If they have the strength and control to do it slowly, then I can ramp up that pace. And for some people, I might be able to ramp up that pace pretty quickly. So, say again, if we go back to that bicep curl, if they can do that at a very slow tempo with no pain and with good control, then I'm going to say, all right, now let's go ahead and start doing it a 1 2 3. All right, a 1 2, now a one pace. And that's where they start to be able to kind of progress. And it's all about just trying to match where are they in their rehab journey versus where they're trying to be at the end. So it's going to be different from everybody. I wish that we could have a strict timeline that told us that every single person is going to strengthen at a certain rate, but it's going to vary. People are going to have good days and bad days. It's a roller coaster ride. It's not an escalator.
Like I said, that's probably one of my favorite things. You get a protocol with a range, like 3 to 4 months is when you can expect to do that. And a lot of that's kind of giving you the guidance of it does take time when you're injured. There's not much you can do about speeding up recovery when it comes to just healing. You have to go through the process of it too. Doing it appropriately so you don't get any setbacks is kind of a beautiful part of us physical therapists being there to know what we're doing to guide people safely. But definitely trying to challenge it and match the patient or the needs, and sometimes reel it back in or push them a little bit harder. And kind of going into that is the different injuries out there. Not every injury is the same. Some of my personal, I guess, triumphs at this point, things that I look back and they challenged me at the time, made me go back to the books, read up on certain things. Certain ones stand out. I did a bilateral femoral osteoplasty for leg lengthening. I love doing concussions. It's something that's very passionate to me, but it's the unobserved injury. People don't know what's going on behind the scenes, so you really got to be there from the biopsychosocial aspect of it too to get to know someone. And even something like more serious, whether it's a stroke with cognitive impairments and trying to figure out, hey, what does this person need? Because not every stroke's the same, or the impairments with the recovery process. So I think that we play a huge role in those. And my personal least favorite, patella fractures. That's I've seen such a range where the same thing that looks way less complicated on an X-ray is the thing that actually was the most difficult because I couldn't get that in the muscles to engage. There was a certain level of I don't know, just apprehension of the patients at certain points. And I think that I know I had a big impact to kind of push people to do it safely, but it did present some challenges, bringing some electrical stimulation to kind of help with that neuromuscular facilitation early on and bridge that gap to get them back to whatever they were doing with that. So I'm sure you know everything you were talking about in your experience. Do you have any specific injuries or patient limitations that stand out to give you a more difficult time?
Oh, I mean, that's a great question. Um, I mean, even just to speak to what you're talking about with that patella fracture, what again, everyone's going to progress differently, but we need to be able to think of it that we're not just addressing a knee, we're trying to treat a person because they're going to be the components with that person of whether or not the joint itself can move, the spinal signals, being able to get to the motor units to actually contract that quad and get it to fire, and then also the psychological component of whether or not they have fear that they're going to re-injure themselves by actually using that. And so, man, for myself, let's see, I can think of a couple of quad tears, like patellar tendon ruptures that happen in young athletes, PAOs or periacetabular osteotomies that have done very, very well, even though it's remarkable that they're going in and actually cutting, reshaping, and actually moving part of the pelvis, and that these individuals actually come back very, very well. I had one who's a police officer who had suffered an accident during training. He came in and he had multiple trauma. He had cervical fracture, clavicle fracture, two separated shoulders. He had another spinal fracture, and then he ended up having bilateral hip pain that necessitated two PAOs. And although it took a long time, we were actually able to get him back to where he was able to be on the force. Now that had a whole lot of ups and downs. It's that we start small, we start doing what we can, and so getting things to move, that range of motion component first, right? You have to clear the road, and then we strengthen through it, so we pave the road. Once we have that movement, we just make sure the muscles can work within that range. And then you start doing things from the table. Then you start doing things in sitting, then in double leg tall kneeling, single leg in the lunge position, then you finally get people on their feet, but it just takes time. You have to try and build back with it. So understanding where they are at in terms of their rehab journey, and then just try and challenge them up to that point. So if you're trying to do the same exercises you were doing last week, you're not challenging them. Every time that I see somebody, I should try to test them a little bit. I should try and push the limit to see that, okay, if I'm loading this person enough, they've done this 3 times, they should be good to be able to either increase the weight or go into a more challenging exercise. Which is why if I'm trying to do strengthening for these individuals, I'm going to tell them I want to do 5 sets of 5 reps. That's going to be what I want to try to do to try and strengthen something. Now, those 5 reps, that can't be at, 20 pounds. I need to understand how much of that 1 rep max or that max voluntary contraction that I'm actually having them work at. If I start early, that MVC is going to be really, really small. Say they're only able to do a knee extension with 10 pounds. Great. So I'm just going to have them work at 10 pounds, five reps by 5 sets. Next week, we're going to try 15. But I need them to be working at that to where by the time they get to that last, rep number 4, rep number 5, we're both asking ourselves whether or not they're going to have the strength to get it. So we need to push our people, which I think a lot of times we underload, we underdose our patients. And that just kind of does a disservice both to them and to us. So we can see better results, they can see better results if we just understand that loading concept.
Yeah, definitely remember going back and being one of the disservices that we do as a profession sometimes is that underdosing. I remember hearing that when we were in school, and it has always resonating to me where people come in, oh, I felt great, like, and let's do that again. And if I come in and see a patient that's been doing the same things, maybe not my patient, I tend to push them a little bit. I have a lot of education on the DOMS, the dreaded delayed onset muscle soreness, but I want them to know like what we're doing. We're trying to build up muscle. We got to tear it down with little micro trauma to it to build it up. So you should have that expected residual discomfort, but it shouldn't be debilitating. It shouldn't last forever. So it's amazing to me, like body emotion stays emotion, but when we're working towards a patient trying to achieve their specific goals, the resiliency and the ability of the body to heal and to come back from certain things. I think people just a lot of times want that quick, easy fix, take a quick pill to get rid of the pain, they're good to go. But to truly, nothing good comes easy, right? Patience is a virtue. So I think putting in the time and effort and some of the guidance, like you're saying, to have someone that knows what they're doing to guide you through that, to safely get you back to those goals. I think it's a huge service when I see PTs or patients are like, "Oh, I did my home program," which is exactly what they're coming in to do, and they kind of lose the value of what PT is. And I think that either discourages them or they think they can just do it on their own sometimes, and maybe sometimes they can. But I do think that that's something that I wish the general public knew that, hey, they're whatever your level is at right now, we should, as physical therapists, be able to push you to that next level and guide you in that safely. So I definitely think that's definitely something that's always stood about out to me, the resiliency. Working in like level 1 trauma hospital and seeing like when you're describing that patient with what do they have, XYZ and all the above. It's amazing to see. It takes time, but to really see those steps, I know the patients love it and that's what they come for. But and for therapists like us, I know you get something out of it. That's why we do what we do and love it, because it's not just because it's creative and fun for us, but the fact that we can see the work of or the progress of our work too, of what we're doing to see how that benefits others' quality of life and how much they can get back to what their normal is. And sometimes they just don't think they'll ever be able to get back to there. But you were talking about like going back to those difficult cases you were treated or treating. What did you learn from those experiences as a physical therapist? And if you could go back now, this is always one of those hindsight's always 2020 statements. But what would you like to have known then and that you know now? And what did you do when you hit some of those obstacles for yourself? Not to call you out on any weaknesses, but for me,
Hey,
my weaknesses and identifying make me work harder to make me better at them. And I think they do turn around to become strengths one day. And I know that you're probably the same way in that. So you probably have a couple of personal anecdotes with that.
sure. I mean, if one thing I try to tell any of the people that come in and mentor with me is you need to separate yourself from how your patients are doing. I found that early on in my career that I would be determined whether I was going to have a good day or a bad day based on whether or not my patients had a good day or bad day. You know, whether or not they were succeeding, whether they were coming in, they were happy, or they were giving me good feedback as to what I was giving them. And if I didn't have any good feedback, I felt like I had a bad day. Or if my patients were having a down day, then I carried that home. And then I came to realize that those can be separate. You know, I am part of their day and they're part of my day. I personally invest in all my patients that I truly want everybody to succeed. I want everyone to feel better. I want them to move better, but at the same time, I only have so much control over that, which is very little. I am really here just to be able to try and help guide you. But whether or not there's that success, it has to be a two-way street. You know, we both have to be able, we both need to be participating and giving in that. And even if we're both giving it our all, there's still that chance that today's just not a good day, right? It might be that your cat died. It might be that your knee is just swollen. Sometimes we've got things that are just swollen and stay swollen, and we can't really overcome some of the body's processes of healing. It just takes time. And so that actually helped me become a better respondent to my patients, to my clients, in that I could be a little bit more positive to them because I had that understanding that we might be doing all the right things and we might still just have to wait. It still just may take time. But no matter what, just as long as we're doing the right things, we address what we can that day. So maybe that's taking a step backwards. Maybe it's trying to push you and we take a step forwards. But don't let that rule whether or not you value yourself as a good physical therapist because you just may be having a bad luck of the draw. As long as you feel that you are giving it your best effort and you have that passion still, your patients will pick up on that and you're going to be able to go home and have your life outside of work and your life inside of work. But just don't let how your patients are doing define your happiness.
No, I love that. I love the answer. And something that stands out with everything you just said, I think that goes into my next question great with it too, because I always want to push people to their maximum potential. I'll tell my patients when they come in, don't look at me as your doctor necessarily, but as your coach, and you're the star player on the team. I want to give you the best playbook and make sure that I'm teaching you so you can learn and go practice it. And you go home, you got to do your home program to be able to load up on it and then be able to progress. Because when you show up at the clinic, that's game time. We're in this to win it kind of thing. But there's good days and bad days. And I know that for me too, I always want to push people to maximum attention. Give them the difficult exercises. Make sure that I'm progressing them, giving them something to work at. That's something new too. That's progressing towards their goals. But it doesn't always work that way. And I must reel it in sometimes too, and just take a step back. When observing a task being too difficult, still when my patients are asking, or when I'm asking my patients to perform them, when you see that an exercise might be too difficult and potentially dangerous when being performed by a client, how do you go about correcting that without making your patients feel like they're failing the task?
Right. So I don't want my patient to feel like they're failing anything. So I actually take ownership of that. I say, whoa, whoa, hey, hey, let me fix something. I didn't do this right. And then I'll say, hey, let's maybe lower this step, or let me change this up so that way I put you in a different position. But I try to mix it up and I own that. I'm not saying that I did anything wrong, but I'm saying, whoa, let me modify this so that way I can make it better for the way that I, the therapist, want. I'm not saying that, well, you can't do this yet. I'm not saying that you're not ready. I'm saying, hey, from my clinical eye, let me make this better.
Yeah, it's it. It's just one of those milestones to get you to that end goal. So we're human too. And I think that the beauty of what we do, we get to see people not once after that 3 months wait to come in and they finally see us. We're at a computer for 5 minutes. We get to see our people several times a week, maybe once a month, or kind of progress them, touch base as needed. So I think we do build a closer relationship. We get to know our patients a little better too. So it helps us to figure out the approach with another person of, hey, we're on the same boat. Like neither of us want this to sink. And we get there when we get there. Sometimes we got to take the scenic route and take it a little bit easier. But at the end of the day, we modify things and we work towards that similar goal and get that quality out of everything we do.